Hello and good morning. My name is Christopher Gardner. I am a nutrition scientist at the Stanford Center for Research in Disease Prevention. I do a lot of nutrition studies. We do diet interventions, trying to lower blood sugar, improve insulin resistance, and that kind of thing. And I'm thrilled to have been invited today by Dr. Nalini Saligram for your 2026 Scientific Symposium, the next frontier in diabetes care. So we all know that diabetes in the South Asian population is rampantly high. There's much that can be done with diet. And so I'm really excited that food is medicine is a topic that is really taking off. I'm assuming a lot of you continue to hear about this frequently. I know that Darius Mosafarian at Tufts University has an Institute of Food as Medicine. I know that one of my colleagues, Dr. Lisa Goldman Rosas, runs a lab here at Stanford where she does all kinds of studies on food as medicine. I know that in 2022, President Biden held a White House conference on hunger, nutrition, and health. And one of the things that came out of that was a pledge with a collaboration from American Heart Association and the Rockefeller Institute to pledge $250 million over the next 10 years to building out food as medicine. Now, as a quick aside, my colleague Lisa Goldman Rosas calls it food as medicine, and the American Heart seems to call this food is medicine. And my quick take on that is part of the studies that I've been participating in and others is really intended to help influence the insurance companies to cover food, just like they do medicine, to reimburse for it. And so if that's a way to get insurance coverage, call it is instead of as, I'm all in. But it really doesn't matter exactly what you call it, because what's so exciting is how many people are recognizing the power of nutrition. We got pilot funding to do a study with heart failure patients and medically tailored meals. And once we get that funding, I was very excited to get it. But I then thought that, well, we're not exactly sure who we can use as a provider for these meals. We don't have our own kitchen. We don't have actually enough money to hire a chef. How can we go through an existing organization? Who's doing this? And it made me quickly realize that Open Hand in San Francisco and Health Trust in the San Jose area and the Ceres Group, CERES, in sort of the Marin Northern California area are all distributing thousands and thousands of medically tailored meals already. They're finding different ways to get it covered. California has some special programs to cover it. Sometimes philanthropy is covering it. It's just a really exciting time to see how many people are stepping up for this. And it's not just medically tailored meals. So let me tell you a way that I heard Darius Mosafarian describe this in a paper written in one of the major medical journals. His impression was that there were three tiers to this, and the top tier was the medically tailored meals, where you are providing fully prepared meals that all you have to do is heat up to those participating. There's a step down from that, which is medically tailored groceries. So this would be a way to provide individuals with food, selected foods that are better for diabetes, but they would prepare them themselves. They'd have to cook them and prepare them and chop them. So that's a little less intensive, but maybe creating a lot more agency because they're cooking their own food. And then the third level has been produce prescriptions, where almost like a CSA box, community supported agriculture, you'd get a box of produce from a farmer. And then it might come with a recipe, might not, but you'd be getting the vegetables and fruits and maybe some other components in there that would help enhance the nutrition quality of your day. So from my perspective, from a researcher's perspective, it seems like it's medically tailored meals, medically tailored groceries, and produce prescriptions. But thinking a little outside the box more than that, there's also been a wave of growth in teaching kitchens, teaching kitchens in hospitals, teaching kitchens in community centers. I've even seen people driving a teaching kitchen in a van with a cart that they stop the car, open the back doors, roll out the cart, set up something with a hot plate and just some simple nutrition tools, some knives and some other cooking utensils. And it's really great to see this teaching kitchen kicking off. Another category here would probably be food pharmacies, right? And in this case, pharmacy isn't PH pharmacy, it's F for food pharmacy. I know that my dear colleague Michelle Hauser has done this, I believe, with the Mayfield Clinic in Palo Alto, where be writing prescriptions as a physician for lentil soup. And then in collaboration with Second Harvest Food Bank, before that patient left the clinic that day, they would go to the food pharmacy and they would pick up all the ingredients to make lentil soup, and it would come with instructions. Meals on Wheels might qualify for this, right? There really are, there's so many programs providing food safety net type options, so many ways to support people. So I really look to the folks that I know in the Palo Alto, Stanford area that are doing this really well. Latha Palaniappan is one of my favorite clinicians who's very much into South Asian health. I know there's a really great South Asian heart clinic in Mountain View, California. So I bet you're all going to have a fantastic day networking with all these other professionals that are around you. I hope you find different ways to advance food as medicine wherever it is you are. This is really wonderful that the enthusiasm is kicking up, but there are a lot of ways to do this. I want to end on one note of caution that came up in the trial that we have. So preceding the trial, actually, I participated in an American Heart Association presidential statement trying to set the landscape where food is medicine was at that time. That was 2023, as directly in response to that Biden White House meeting. And we were looking for the evidence that existed and what new evidence we needed to move this forward. And one of my jobs was to review the literature. And I was specifically looking at medically tailored meals. So let me be a little provocative about this. What does medically tailored mean, whether it's meals or groceries? So is the tailored part to the health condition? Is it tailored to diabetes versus heart disease versus kidney disease? That would be one way to think of tailoring that. So for diabetes, you might be very concerned about added sugars and refined carbohydrates. For cardiovascular disease, you might be more concerned about saturated fat. For kidney disease, you might be concerned about not getting too much protein and exacerbating that impaired kidney function. Okay, but for the studies that I looked at in the literature where they were trying to say, we are doing food as medicine studies, we're trying to move this along, pretty much every study I found was either only in people with diabetes, only in people with heart disease, only in people with kidney disease. So how would you test the tailoring of the meals if the whole population has the same health condition? And what I recognized really quickly was how important the other side of tailoring was. Tailoring for culture, tailoring for preferences, tailoring for allergies. And so think of all the meals that might get delivered, prepared and delivered to help somebody out that don't get consumed because it isn't consistent with somebody's culture, right? Or it isn't taking into account their allergies. So we tried to do one of these studies very specifically in patients with heart failure. And so we weren't tailoring for their condition, but we were tailoring for their preferences, allergies, and culture, working with a group that found that it was really challenging to take a group of people and create a separate meal for each person that had all those different special needs. As hard as it is, that is the direction we have to go. If you are helping someone and providing food, and it isn't tailored for those extra special things, not just the medical condition, but all the things that are so important to having it work out in social settings, having it work out with your family, having it work out with your preferences and your culture. If you get those meals delivered and you don't eat them, I can promise you they won't do you any good. Okay, so another colleague here, Minal Mohari, is making many of these tailored meals for South Asians. She is an occupational health doc here at Stanford. And she was running into people who said, yep, I know you prescribed a Mediterranean diet, but that's really not what I eat, doc. I'm South Asian. So she's created a wonderful program of delicious menus that she calls Nourish. And I love watching her build that program as well. So it's an exciting time. There's work to be done in this field. I'll bet you talked to lots of colleagues at this conference today about this, and I really hope you can help move the needle forward. Diabetes is a huge concern right now, but nutrition is so powerful, specifically for diabetes. So I think there is plenty of room for improvement. Some of my greatest friends right now are at the Culinary Institute of America, chefs that are helping me appreciate how much people prioritize taste. So couldn't we make unapologetically delicious food that is good for our health at the same time? I'm a little sad when Americans seem to think the healthy food choice is not the tasty food choice. So I'm challenging you all today to think of food as medicine, to think of retaining the joy and pleasure of food, but using nutrition and delicious food as a lever to prevent and treat diabetes, which is really rampant and running out of control right now. We need all of you to work on this. Have a spectacular day with the fantastic schedule and speakers that are ahead of you. It's been an honor to welcome you this morning. Have a great day.